Good morning, dear colleagues. Today we will talk about the basis of immunohistochemistry. Immunohistochemistry is a science that combines the techniques of biochemistry and histology in the study of the chemical constitution of the tissue and cells. Immunology is a science that deals with the immune system, cell-mediated and humoral aspects of the immunity and immune responses. Immunohistochemistry is the localization of the known antigen in the tissue by the using of antibodies direct toward a specific antigen. So, immunohistochemistry combines histological, immunological, and biochemical techniques for the identification of specific tissue components by means of the specific antigen-antibody reaction touched with a visible label. Immunohistochemistry makes it possible to visualize the distribution and localization of specific cellular components within a cells or tissue. The main principle of the immunohistochemistry has existed since the 1930s. Kunz in 1941 identified pneumococci with the using of direct fluorescence method. Stenberg and Milstein synthesized first monoclonal antibodies in 1970s, and for that research, in 1984 they received Nobel Prize. First peroxidase and anti-peroxidase techniques start used in 1979. Use of avidin biotin complex began in early 18s. What cell antigen can be targeted? First of all, it's a cytoplasmic antigens which present in the cytofilaments or maybe in organelles. Then nuclear staining, nuclear antigen. Third, cell membrane, and also separately may be lipids and proteins, which localize in the extracellular matrix. On these slides, you can see the main step of immunohistochemical procedure. At the beginning, we take the sample of tissue and cut it into the small pellicles by the using of the microtome, and then we must put these pellicles into the slide and start other steps like antigen retrieval, blocking of the antigenic enzymes, adding of the primary and secondary antibody with it, which more often labeled by the chromogen substrate. Then we using the counterstain and mounting. Slide which is ready for use, give for the pathologist for the microscopical investigation. The first step of immunohistochemistry, that is a fixation. More often we use the fixation in the 4% formaldehyde with the phosphate buffer. But also we can use frozen fixation by the using of the liquid nitrogen. Liquid nitrogen fixation, very interesting and important technique for the best identification of the cell membrane antigens and cytokines. But generally it's difficult to make a series of the slides. So when we use fixation in the formaldehyde, we must put the sample of tissue into the formaldehyde in the 24-72 hours. Its duration of the fixation procedure is connected with the tissue properties and also with the size of the sample. Of course, gastrobiopsy, which is several millimeters in size, must be present in the formalin not more than 24 hours. But if it's big part 1 to 1 to 0.3 centimeter in size, for example, from the leiomyoma, may fixed longer, 24 from 24 to 48 hours. After that, we are put this prepared tissue sample into the paraffin, and paraffin fix the tissue, and we may cut it. For the cutting of the tissue sample, we use microtool, which cut the tissue into 2-4 micrometer pellicles, and we put these pellicles into the slide. After that, we must make a deparaffinization of the tissue. Tissue is treated in the series of xylene and alcohol for the removing of the paraffin. Third step, it's the antigen retrieval. Enable the partial reversal of formaldehyde-induced conformational changes of the antigens. If we want, we must increase the accessibility of the antibodies to the antigen. In this case, we must use two methods of the antigen retrieval. One of it is a heat, and the second is an enzyme digestion. Choice of the antigen retrieval depends on the antigen which will be demonstrated. First, heat. Here, it's a heat-induced epitope retrieval. It's more widely used. For that, we must heat the tissue to the temperature up to 100 degrees Celsius, which can be achieved by microwave oven, pressure cooker, or vegetable steamer, or water bath. But will be better if you used automatic immunostainer. The cooling off section slowly allows the proteins to refold properly. Other variant, that is the pretreatment by the blocking of the endogenic enzymes. That can be a peroxidase block or protein block. If we used peroxidase block, we block endogenous peroxidase with the using of the 3% of peroxide. Protein blocks all non-specific sites. It's reduced the background staining with the using of the endogenous peroxidase and endogenous biotin. For that, we use 10% normal serum. Here you can see two pictures, the one of it with the using of the antigen retrieval and other without it. And on the left picture you can see a lot of atypical, abnormal, additional brown color staining, and here you can see just clear focus with the antigen antibody reaction formation of the labeled by the chromogen immune complex without any negative additional reaction. Antibodies. Antibodies can be different. According to their region, it can be mouse, rabbit, goat, sheep, and other. According to the clonality, by the clonality we can classify it into the polyclonal, monoclonal, and cocktail. Monoclonal antibody, that is, when we have different clones to the different epitope of the same antigen. We make an immunization of the mouse by the antigen, isolated immune cells with the antibodies, then fused this antibody-containing cell with the tumor cells, that is lymphoma cells, and then this cell begin progressively proliferate and forms multiple antibodies. When we remove it, we received monoclonal antibodies. Here you can see that's the monoclonal Antibody cocktails also can be present. It's a mixture of different antibodies in the one bottle. And the last, it's a polyclonal antibodies. It's a mixture of the different clones to different epitopes in one bottle. Monoclonal and polyclonal antibodies have minuses and pluses. For investigation in science, better use monoclonal antibodies, but it's cost more than polyclonal, so it's more expensive. Polyclonal is cheaper, but it's have sometimes non-specific reactivity, but affinity is better, so we have some pluses and minuses. Also, antibodies can be divided into the ready-to-use and concentrated. Ready-to-use is when we can take it and use directly, and concentrated we must resolute it. Next step, that is a visualization or detection. For that, we can use direct and indirect method. Direct method, it's labeled antibody reacted directly with the antigen in the tissue section. It's a single-step method. It's short and quick, but extensively due to the little signal amplification. We have only one signal here. Indirect method. Unlabeled primary antibodies react with the antigen, and the labeled secondary antibodies react with the primary antibodies, like with the antigen. Like this: antigen, primary antibody, and secondary antibody, whether fluorescent or any enzymic talk, and all they are react with each other. Indirect method is sensitive due to the signal amplification. Economical, as a single secondary antibodies can be used against many antibodies from the same species. Detection method. Antigen-antibody conjugates are visualized by the use of the labels. Enzymes that produce a color precipitate in the presence of a substrate are used as labels. Labels can be peroxidase, alkaline, phosphatase. Detection system in a direct and single-step method, and indirect or two-step method. Now we will talk about enzyme labels. Enzyme labels produce a color precipitate in the presence of specific substrate. Most widely used label is a peroxidase. It's stained into the pink color, and also maybe brown color precipitates when diaminobenzidine is added. Alkaline phosphate is also used and produce either red or blue precipitate. DAP or diaminobenzidine, it's a toxic substance, so we must be very attentive with this procedure. Next step, it's a counterstaining. Provides contrast to the primary stain. Most commonly used counterstain with gematoxylin-azine. It's considered to be gold standard in immunohistochemistry. Gematoxylin stains nucleic acid blue, while azine stains eosinophilic structure in shades of red, pink, and orange. So we can see the brown color immunohistochemical reaction products on the base of the pale blue color tissue. Nucleus more bluish than the other tissue. 7. Controls. Each markers which used in the human tissue must have a positive and negative controls. Each reaction which we make in immunohistochemistry. Cellular tissue. Positive control. What is it? Cellular tissue that are known to contain the specific antigen. detects false negative due to the fixation and processing. It is used to validate the protocol or procedure used. So we must have positive control. Negative control, omission of the primary antibody with the same tissue and procedure. Useful to detect endogenous binding and epoxidase activity. On these slides, you can see special apparatus for the fixation and for the staining. It's immunohistochemical staining, and that is a staining, simple staining. On this picture you can see labyrinth with a microtome and water bath. So now we turn to the aims of the immunohistochemistry. On these pictures you can see left side pictures which stained with the gematoxylineazine and right pictures with immunohistochemistry. First, Helicobacter pylori. You know that microorganism which cause gastritis, duodenitis, chronic peptic ulcer of the stomach or duodenum. It's very important to know the presence of this microorganism in the mucosa of the stomach. We can do that with a lot of different methodics, but all these matters, it's not direct, it's not real, it's not so sensitive like immunohistochemistry. When we use immunohistochemical identification of the Helicobacter pylori, we can see this microorganism by our eyes. And here you can see the gastric pits with a lot of the brown color dots and sticks. And these sticks, brown color sticks, it's a Helicobacter pylori. These slides show us differential diagnosis between the large cell carcinoma and large cell lymphoma. Large cell lymphoma and large cell carcinoma has the same histological picture. It's composed of the blue color cells with a very big nucleus and a small amount of the cytoplasm, small thin rim which localized around this nucleus. So we must differentiate if this tumor is large cell carcinoma or large cell lymphoma because the treatment will be different. Large cell carcinoma, it's a malignant tumor from the epithelium, and epithelial cells have the positive reaction with the cytokeratins. And in this staining, we use cytokeratin, pan-cytokeratin, and it has positive reaction, brown color staining, and in the tumor cells. CD45, that is the markers of the lymphocytes, pan-lymphocytic, but it's negative in the tumor mass and positive in the reactive intratumorous lymphocytes. As you know, each tumor will be surrounded by the lymphocytic rim because our immune system tries to protect us, try to control these atypical cells and want to kill it. But unfortunately, not in all cases it's possible. Here you can see differential diagnosis of the large cell carcinoma and a malignant melanoma. Both of these tumors, malignant tumors, compose of the big cells with the white pinkish color cytoplasm with oval or irregular shape nuclei with a multiple mitosis, with atypical mitosis. So, what we do? We use markers of the cytokeratin, markers of the melanocytes S100 and HMB45. In this case, cytokeratin was negative. It stained only epithelial layer which covered this tumor. And S100 give the bright positive brown color reaction in the tumor mass. HMB45 also have a positive reaction in the tumor cells. So our diagnosis is a malignant melanoma. Here you can see markers which we used for the gemoblastosis, like CD3 is positive for T lymphocytes, CD20 is positive for B lymphocytes. Typical marker for the Hodgkin's lymphoma, that is CD30. Generally, we never can give the diagnosis of any gemoblastosis or any lymphomas without immunohistochemical staining. Only immunohistochemistry can help us to know the main cells which have a pathology, which cells that give the growth for the malignant tumor, and of course how to treat this patient. Here you can see more widely used immunohistochemical investigation, that is the investigation of the invasive breast cancer. For the breast cancer, we used 4 main markers like HER2/neu, like estrogen, progesterone, and Ki67. We will talk about it later. Here you can see also immunohistochemistry with the staining of the basal cells by the cytokeratin 903. Here you can see the benign hyperplastic reaction in the prostatic glands. In the prostate cancer, if we have no basal cells, we talk about the prostate carcinoma. For the identification of the basal cells, we use cytokeratin 903 or maybe P63, it's also cytokeratin. And these markers give us possibility to differentiate malignant condition, cancer of the prostate, from the benign prostatic hyperplasia or just a simple gland. Here you can see first left side colors slide. That is a picture with a prostate cancer, possible cancer, but it's stained with gematoxylin. In PCA reaction, prostate-specific antigen, we have the positive reaction, so it's a prostate cells of the prostate gland, positive reaction. And here you can see that cytokeratin 903 give the negative reaction, so no one basal cell present in this tissue, no basal cells, so it's adenocarcinoma. And our final diagnosis for this sample will be foamy adenocarcinoma of the prostate gland, Gleason 3. Here you can see also example how immunohistochemistry can help us. On the upper picture, we can see a red color patches on the skin, which is slightly elevated above the skin level, and it has a round or round oval with a fusion shape, but it's look the same, but it can be different histologically. In the left side, it's a lichen planus. In the right side, it's a sarcoma Kaposi. It's a malignant tumor. When we stain this part of the tissue, which after the biopsy from the lichen planus, we will see positive reaction with the CD4, CD8, and CD68, which talk about chronic inflammatory reaction in the derma. In the right picture, in the case of sarcoma Kaposi, these markers will be positive just maybe in single reactive lymphocytes, but the tumor mass will compose of the CD34 positive vessels. Here you can see diffuse expression with the CD4, endothelial positivity in CD105, focal expression of c-KIT, and the focal expression of the smooth muscle actin. Ki67. It's a marker of proliferation of the cells. Only nucleus of the cells which undergo proliferation will stain into the brown color. It's very useful markers. We can count the proliferative cells and we can know what will be the future of this tumor. How we can use immunohistochemistry in oncology? First of all, for histogenetic diagnosis of the tumor, for identification of the type of neoplasia. We can differentiate the primary tumor and tumor metastasis. We can make a prognosis, routes of malignant transformation, possibility of the target treatment, that's very important now, resistance and sensibility to the chemotherapy and radiotherapy. Now we will talk about the identification of the tumor of unknown primary site. Tumor of unknown primary site is defined as a group of metastatic tumor for which a standardized diagnostic workup fails to identify the site of origin at the time of the diagnosis. As you remember, metastasis, that is a tissue particles, tumor particles, which seated in body of the patient, so like a distant spreading of the tumor cells. Pathomorphological diagnosis of the metastasis of unknown primary, first of all, based on the routine histological investigation with the using of the chemotaxylin agent. Then we can add the histochemical method if it's possible, if it's needed, immunohistochemistry and electron microscopy. Here you can see the table with the first step of the identification of the metastasis from the unknown primary site. How to differentiate carcinoma from another neoplasm. First of all, we use 4 markers like pancytokeratin, CD45, S100 or HMB45 and vimentin. In carcinomas will be positive only pancytokeratin and vimentin. In the malignant lymphoma, hemoblastosis, we will have a positive reaction with the CD45 and sometimes vimentin. Malignant melanoma will be positive with the S100, HMB45 and vimentin. And sarcomas, as you remember, that is a malignant tumor of the mesenchymal region. It will be positive only with the vimentin. When routine morphological diagnosis of metastatic tumor, according to the recommendation of the ESMO 204, it is advisable to divide into the 5 major categories: adenocarcinoma, squamous cell carcinoma, neuroendocrine cancer, undifferentiated cancer, and undifferentiated tumor. On the second step, we must review the histomorphological without clinical information, generate a broad differential diagnosis. So if we have no clinical information, we can make the short list of the tumors which give the metastasis. We must include clinical information like age, sex, tumor location, and prior malignancy. Evaluate the histomorphologically and formulate top 1-3 possible diagnoses. And if we have a tumor with a definite lineage differentiation such as adenocarcinoma, carcinoma, we use first of all cytokeratin 7 and cytokeratin 20. If the tumor has no clear lineage of differentiated, we may use, as I said before, panleukocytic marker, pancytokeratin, S100 and vimentin. According to that, we will separate the tumors. Here you can see this step number 3. If we talk about adenocarcinomas, about the malignant tumor of the epithelial region, it's maybe positive for cytokeratin 7, negative for cytokeratin 20. Cytokeratin 7 negative, cytokeratin 20 positive. 7 positive, 20 positive. Cytokeratin 7 negative and 20 also negative. And for each of these groups, we have a lot of tumor diagnoses. So we separate into the 4 main groups with the help of cytokeratin 7 and cytokeratin 20. Then we added another markers, another antibodies, and with the help of these additional markers, we can separate the tumor which we need for us in this investigation. Turn to example. Here you can see the histological view of the metastasis of adenocarcinoma G2 with a necrosis into the amentum. What do we have? A woman, 47 years old, with a abdominal and low back pain. She visited a lot of doctors and finally she goes to the ultrasound examination. On the ultrasound was found multiple nodes in the abdominal cavity and in the amentum. Under the laparoscopic investigation, doctor received histological material for histological investigation. On the histology, as I said before, we have growth of malignant tumor in the amentum. We start with the first step. Differentiate, is it carcinoma or maybe not. We have pancytokeratin, CD45, S100 and vimentin. In our case, only pancytokeratin gives the positive reaction. All other markers in the tumor mass was negative. So that is the metastasis of the adenocarcinoma, carcinoma generally. Step number 2. We added cytokeratin 7 and cytokeratin 20. Cytokeratin 7 was positive, cytokeratin 20 was negative. According to that, we receive 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 15 possible diagnoses of the tumor. What we will do? We also must separate some tumors. With the help of estrogen and progesterone, we can separate only tissues which have a positive reaction with the steroid sexual hormones. That is an endometrial tumor, ovarian tumor, and breast tumor, and also cervix, of course, cervix of uterus also. So we take the estrogen. We also take the TTF1, CDX2, WT1, CA125 and PAX8. What we have? Estrogen gives a positive reaction. TTF1, which normally positive to lung and thyroid gland, have a negative reaction. CDX2, which positive for tumor of the colon, bladder, stomach, endometrium, also give us negative reaction. WT1, which normally stain ovarian carcinoma, serous type, give us positive reaction. CA125, which normally stain gives a positive reaction, stain with the biliary tree tumor, breast tumor, cervix, endometrial, fallopian tube tumors, liver, lung, and ovary, pancreas, give us positive reaction. And the last, PAX8, normally positive in ovarian carcinoma except in serous type. So our diagnosis according to the immunohistochemical reaction was high-grade serous ovarian cancer with a metastasis to the amentum, sitting in the abdominal cavity. It's of course deep stage of the cancer. It's very difficult to treat patient in this period, but of course chemotherapy is possible. Next example, case number 2. Patient with a nodular formation in the left lung. In anamnesis, we know that this patient have the cancer of the right kidney in the 2012. So 7 years ago, this patient have a cancer of the kidney. According to TNM, that tumor was T2 and 0M0. What it mean? T2. It's a tumor more than 7 cm in greatest dimension, but limited to the kidney. And 0. No regional lymph node metastasis. And M0, no distant metastasis. But that was in first investigation in 2012. What do we have now? With the help of thoracoscopy, was taken the sample of the tumor mass from the lung of this patient. Tumor cells is with a prominent cell borders, finally reticular pale cytoplasm with a perinuclear hollow and wrinkled rhizinoid nuclei. What is it? Is it secondary tumor, which is metastasis from the kidney, or maybe that is a primary tumor of the lung? We must know it. How we will do that? With the help of immunohistochemistry. First of all, cytokeratin 7. It gives the membranous or cytoplasmic reaction with expression in many normal epithelia and epithelial tumor. Despite wide distribution, useful as a part of the panel in determining primary site of metastatic carcinoma. Generally expressed in adenocarcinoma of the lung, breast, thyroid, endometrium, cervix, ovaries, salivary gland, and upper gastrointestinal tract, urothelial carcinoma, papillary renal cell carcinoma, and the Paget disease. And here you can see the bright positive reaction in the tumor mass. Next marker, which we used, TTF1, thyroid transcription factor, also called thyroid specific enhancer binding protein. It can help us to distinguish primary lung tumor from the metastatic one. And we can see that the TTF1 was negative in the tumor mass, but positive in the surrounding lung tissue. So that is a metastatic tumor. We know about the anamnesis of the patient, so we added PAX8. PAX8 normally help us differentiate primary or metastatic tumor of the kidney, thymic, thyroid from the PAX8 negative tumor of the adrenal gland, breast, gastrointestinal tract, lung, and prostate. We have the positive reaction in the nuclei of the tumor cells, so that is a metastasis from the kidney or from the thymus or from the thyroid. But we know that TTF1 is negative, so we can exclude thymic, thyroid, and we have only ovarian and kidney. CD10, cell membrane metallopeptidase, widely distributed in the hematopoietic cells and their neoplasm, also called common acute lymphoblastic leukemia antigen. In a kidney, it can distinguish renal cell carcinoma, clear cell type, eosinophilic variant, which is CD10 positive, from the chromophore carcinoma, eosinophilic variants, or oncocytoma. In our case, CD10 was negative, so the final diagnosis was chromophobe carcinoma or metastasis of the chromophobe carcinoma of the kidney into the lung. Here also we have some additional staining like vimentin, which give us staining only stroma of this metastasis. Normally, vimentin stain endothelial cells, fibroblastic reticular cells, fibroblast, interdigitating dendritic cells, Langerhans cells, and vascular smooth muscle cells, and other cells of the mesenchymal origin. So, that is a blank with the answer. Clinical diagnosis: metastasis into the left lung. Conclusion of the immunohistochemical investigation: cytokeratin 7 positive reaction, TTF1 negative reaction, PAX8 positive reaction in tumor cells, CD10 positive reaction in focal tumor cells, vimentin negative reaction in the tumor cells. Conclusion: morphological picture and immunophenotype of the tumor mass accompanied with metastasis of the chromophobic variant of the renal cell carcinoma into the lung. Now I want to show you the possibility of the target treatment, which is mostly used for the breast cancer. One important aspect of the role of pathology in the evaluation of the breast cancer is the biomarker testing, specifically the accurate assessment of the estrogen receptor, progesterone receptor, Ki67, and HER2 status of the patient with breast cancer. Biomarkers can be prognostic, predictable, and both. Prognostic biomarkers are independent measures of prognosis such that the presence or absence of the biomarker is associated with the patient's overall clinical outcome, risk of recurrence, and mortality. Predictive biomarkers, in contrast, predict whether or not a patient will respond to the given therapy. If the patient's tumor expresses estrogen and progesterone, as seen in approximately 7% of invasive breast cancers, we can predict that this patient will likely benefit from the endocrine therapy such as tamoxifen. The overexpression of the oncogene HER2 in patients' breast cancer, as seen in approximately 15–20% of invasive breast cancer, is an example of both a prognostic and predictive biomarkers. HER2 expression is associated with a diminished prognosis, the high risk of recurrence, aggressive growth, and fast metastasization. However, it also predicts that the patient will more likely benefit from the anthracycline and taxane-based chemotherapies and directed therapies that target to HER2 trastuzumab, but not to endocrine-based therapy. HER2 status is initially assessed by the immunohistochemistry measuring protein overexpression. Cases which are equivocal for protein overexpression are assessed by the fluorescent in situ hybridization, which assessed HER2 DNA amplification. So when we give the conclusion for HER2 status, we can talk about HER2 negative, HER2 lower expression like 1+, or HER2 overexpression like 3+. If we have 2+, it's like moderate when we're not sure is it positive or it's negative. And in this case, only in situ hybridization can help us because we must find the initial gene mutation. On the basis of the immunohistochemical reaction, we can classify breast cancer into the molecular subtypes, and according to that we can treat the patient. Lamina A, it's when we have positive estrogen reaction, positive progesterone, negative HER2, and less percent of proliferative cells. It's Ki67 index less than 14%. These breast cancer are low grade, tend to grow slowly, and have the best prognosis. Lamina B, estrogen positive, progesterone positive, HER2 positive, and high level of proliferative activity. This cancer generally grows slightly faster than laminar A cancer, and their prognosis is slightly worse. Triple negative or basal-like cancer, breast cancer. It's a situation when we have estrogen negative, progesterone negative, HER2 negative, or and a higher proliferative rate. That is more common in women with BRCA1 gene mutation. Researchers are not sure why, but this type of cancer also is more common among young and black women, and it's very aggressive, very difficult to treat this woman, because if we have no estrogen progesterone receptor, so we can use the endocrine therapy. If we have no HER2 receptor, so we can't use trastuzumab. And the last type, it's a HER2 enriched cancers, tend to grow faster than laminar cancer and can have a worse prognosis, but they are often successfully treated with the targeted therapies aimed at the HER2 protein, such as HER2, chemical name FAM, trastuzumab deruxtecan, and gerciptin, trastuzumab. Here you can see also how the immunohistochemistry can help us to diagnose the chronic endometritis. Chronic endometritis, it's very interesting pathology which has no any clinical picture except infertility. When the woman wants to have a baby, and the implantation is impossible because of the chronic inflammatory process in the uterus, and no one other clinical symptoms, no pain, no discharge from the uterus, etc. Only infertility. So how we can diagnose it? We can diagnose the chronic endometritis only with the help of the histological investigation of the endometrium and with the help of the immunohistochemistry. For that, we used CD138. It's a Sindecan. It's a marker of the plasma cells. If it's present in the endometrial stroma, so we talk about the chronic endometritis. Only one cell, it will be chronic endometritis. In this case, the woman must be treated by the antibiotics, with aggressive antibiotic therapy, and then after the repeated histological investigation after the treatment, maybe they may have babies. Also, immunohistochemistry can be used for the roots of malignant transformation. Here you can see P63. It's a tumor suppressor gene. Mutations are among most common detected genetic abnormalities in the human neoplasia. However, presence of the P53 mutation is usually not by itself specific enough for the diagnosis of malignancy, and its absence does not rule out of malignancy. Here I want to show you P16. It's a marker which is normally positive in the cells which are affected by the oncogenic variants of the human papilloma virus. And if we see in a woman cervical intraepithelial neoplasia, we may use these markers P16, and if it gives a positive staining, we know that this woman has HPV infection, so it's very often may transform to the cancer, to the malignant tumor of the cervix. One more method, it's a double staining. When we have two markers in one tissue, one secondary antibody labeled one by the one by the one color and another with a second. For example, P63, it's a markers which normally stain in the nucleus, and we have positive staining brown color in the nuclei. And cytokeratin 5, it's normally have a reaction in the cytoplasm, and we have here the pinkish color reaction in the cytoplasm. It's not very commonly used. It's rare, more scientific like method. Histogenic diagnosis of tumor. I show you in here staining with the prostate-specific antigen, brownish color product of reaction. It's a specific antigen which present only in the prostate cells. Very often we use immunohistochemistry in the scientific research, and here you can see our investigation of the histological and immunohistochemical structure of the pelvic peritoneal adhesions. And here the staining was with the CD68. CD68 is a marker of the macrophages, and it's positive. A lot of positive cells was in the adhesions. Conclusions. Application of appreciated immunohistochemical panels enable the accurate classification of most undifferentiated neoplasm or tumors. Knowing the utilities and pitfalls of each tissue-specific biomarkers is essential for avoiding potential diagnostic errors, because an absolutely tissue-specific biomarkers is exceptionally rare. Thank you for your attention.